Well, hello everyone. Welcome to today's webinar of JACC case reports on procedural complications. My name is Poonam Velagapudi and I'm a structural interventional cardiologist at the University of Nebraska in Omaha. We have with us a great panel and associate editors from the journal who I'll introduce next. We have Dr. George Dangas, professor of medicine at Mount Sinai School of Medicine. He's the Director of Cardiovascular Innovation at the Zina and Michael Weiner Cardiovascular Institute of the Mount Sinai Medical Center. We have Dr. Ajay Kirtane, who is a Professor of Medicine at the Columbia University Irving Medical Center. He's the Director of the Cardiac Cath Lab at the New York Presbyterian Columbia University Irving Medical Center. We have Associate Editors, Dr. Eric Bates, who is the Deputy Editor for JACC Case Reports. He's a Professor of Medicine at Michigan University. We have Dr. David Fischman, who's Associate Editor for JACC Case Reports. He's a Professor of Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. He's the Co-Director of the Cardiac Cath Lab and also the Director of the Interventional Cardiology Fellowship at Thomas Jefferson University. And lastly, we have Dr. Mladen Vidovich, who is also Associate Editor for JACC Case Reports. He's a Professor of Medicine at the University of Illinois at Chicago and the Chief at the section of cardiology at Jesse Brown VA Medical Center. I will let Dr. Eric Bates present our first case, which is iatrogenic coronary dissection during PCI investigation and management.
Thank you very much and welcome everyone. This is a very interesting report on a rare complication that we've all seen, but we don't talk about much. This is a 78-year-old man who was undergoing an elective PCI. They used radial access. They were trying to treat a stenosis in a shepherd's crook right coronary artery with a fair amount of calcium. So the key point is they decided to use a 0.75 Amplatz catheter to try to intubate the right coronary artery. They thought they placed the catheter correctly, but they immediately noted a guide catheter dissection that extended both into the right coronary artery and also included the aorta along the os of the right coronary artery. ST segments went up. They had some difficulty rewiring the artery. Let's see the next picture, please. That's the diagnostic challenge with a tight stenosis after a small shepherd's crook. Next. There's the aortic root dissection you can see. So they had to reaccess the coronary artery, get a wire down the true lumen, and then they had difficulty getting a stent. The shepherd's crooks, they had to use an extension catheter and ultimately were able to stent the coronary dissection back to the os and the ST segments resolved, but then they were left with this shadow on the aortic root consistent with aortic dissection. So the clinical challenge, since many newer operators have not had this complication, is what to do next. So they did an emergency echocardiogram to exclude aortic regurgitation from a retrograde dissection. They did not see a pericardial effusion, so coronary perforation was not evident. And then they transported the patient straight to radiology for an emergency aortic CT angiogram, which disclosed no compromise of the innominate artery and fortunately a good thrombus formation in the false lumen. So instead of going to surgery, they decided to watch the patient in the intensive care unit. And when they repeated the CT scan the next day, the false lumen was mostly thrombosed and perfectly stable. And when they brought the patient back for a long-term follow-up aortogram, the dissection was completely healed. So the challenge here, number one, is how to deal with an aortic dissection. Do you go to surgery or do you sit and watch it? The ideal thing, of course, is to not have this complication. So when we discussed this in the editorial board, David said he sees this all the time. I, of course, said that we almost never see it, that I've only seen it a couple of times in 40 years with the The trick is, in the old days, we had stiff catheters, and the old guys are much more concerned about the initial intubation of the coronary arteries. I'm not sure that concern is as high in younger operators with soft tips and softer catheters, and not seeing complications very often anymore. We used to have lots of coronary dissections later, 9 French guide catheters. So the trick is to gently put the catheter in, and I'd be interested from the panel to see if any of you would have called surgery and gone to surgery with this. It may be that this is a subintimal dissection and not a medial artery dissection. I don't know if anybody else knows about it. It's probably different than a spontaneous coronary dissection and more like SCAD. But this case suggests that it heals spontaneously in most instances, and you don't have to do high-risk emergency surgery. Any thoughts?
The first thought, the first reflection I want to make here is that not only do we have the softer and more slick catheters, but also we have the guide extension catheters, and perhaps avoiding an aggressive guide to begin with and planning to utilize the guide extension might avert some of those complications, because clearly the bigger guide here had the difficulty to maneuver and disrupted the situation around the ostium. Now, on the second part, the disruption is exactly at the ostium of the RCA, and presumably the stent, if it comes properly all the way to the ostium, is closing that entry. If that is true, then naturally this dissection, this flap will just thrombose over the time. Now, if we're not sure, or the manipulation was excessive away from the ostium, and we suspect that there is another entry away from where the stent may cause a tamponade, then the situation might be a little bit more different. But for the case that with only an ostial dissection, there could be a case made here to favorably follow it rather than go to straight on to an operation that in the end of the day might not be needed, because this is a very special kind of dissection.
Yeah, I would agree entirely with George and say that, the two things is, I think in the radial era, people have become a little bit less meticulous about true coaxial alignment of diagnostic catheters and guides. Look, it's okay if the guide or the diagnostic is hanging out and you want to take a non-selective shot, but once you start intervening, that can really cause problems because you're injecting dye typically, and that's what causes these dissections, and then they can also propagate retrograde up the aorta. So you have to be really cognizant. The other thing that I see problematic at times is people will advance wires really quickly, and if the guide is not coaxial, sometimes you can get under something and dissect with a wire if you don't come out carefully with the soft tip wire. And then all the points George made and Eric made about the management of this, I think are totally valid. You don't want to keep injecting, because the more you inject, the more you can propagate it back up the aorta. But if you're able to seal the origin of it, then these can routinely be managed conservatively. Call the surgeons, have them on board, do CTs. You don't always have to get a CTA. You can get a non-con CT to be sure the hematoma is not advancing, and follow the patient as long as there's no signs of hemodynamic instability or worsening ST segments on the EKG.
Your points are so important, and we don't see this all the time, but yes, once or twice a year we do see this. And I think the points about a meticulous attention to your manipulation of your guide, your wires. And I look at the fellow's eyes all the time to see, once they intubate the vessel, are they looking at the pressure tracing before they start injecting? And so it's so important to instruct young trainees, how important that pressure tracing is before you start injecting these coronary osteums, particularly if they have a lot of disease. One question I'll ask is, have individuals seen this? I know Eric hasn't seen it too often, about with the use of these automatic injectors, the assist device. Some people say there's a higher likelihood because of the pressures, and are we paying close attention to those pressures?
That's actually a very good point, David, because some people are actually vehemently opposed to power injectors, and especially when they do CTOs. because they feel they have less control with the injection, and that injection of a power injector could propagate a dissection. I'm not aware of the data. I don't know if anybody else is.
I don't know if there's data. What I would say though is that I've seen it both ways with manifolds. I've seen it with automated injectors. I can tell you though that what you said is so true, that you have to look at people's eyes when they're doing the cath. You know, are they stepping on Sine, looking at the pressure and then looking at the angiogram, or are they just looking at the angiogram and just going? So those types of meticulous points can salvage these situations, which are rare, but they're rare enough that they're memorable enough that you remember them very well when they happen. Thankfully, though, they're rare.
Yeah, coming back to the power injector scenario, the power injector doesn't do anything. The fact that it's not adjusted well does everything. So if you have a tricky scenario, you know, there are three or four options there that you can save, and you can have a 2 for 3, or, you know, like a really minor injection setup with a low pressure. And if you do that, you can just use it. But of course, if you go and inject 5 or 10 in the RCA during a CTO under this guiding scenario, it's not really the power injector's problem here. It's just that it's not the utilization is not maximized as it should, and the settings are not set appropriately.
So George, how often do you change the settings on your power injector? I have to say, is if anything, I actually increase them rather than decrease them. Are there any special situations where you decrease your rate and flow?
If I want to save the dye, I decrease I decrease. If there's a slow injection, a low injection is to see just about where you are for catheter positioning. Or, you know, if you have a CTO situation, you may need really small injections.
For instance, have a guide extension, you might think about, you know, fusing to 2 and 1. And the other scenario that can also happen is if you use power injectors, you have to make sure for every shot you look at the power injector and what the settings are. I have a very memorable case of a patient that we were intervening on the LAD where the setting was on the V-gram, and put the guide up and didn't change the setting, and so injected like 20 cc's before we stopped at high flow rate into the left main. And luckily it didn't dissect, but it was Brady almost asystolic arrest until, you know, things settled down. So just make sure you look at the injector as well and what the settings are.
Well, famously, the first coronary angiogram was done exactly like that, with a power injector in the right coronary. So anyhow, we got to really adjust injectors smartly if you want to use a power injector.
All right, we will be moving on to the next case. I just want to give a quick 2 or 3 points for early carriers, particularly when you see this. It's important to call for help. Make sure you call your CT surgeon, your colleague. Make sure you don't inject into the dissection, and make sure the patient's okay, and try and get a bedside echo quickly if you have to do a pericardial effusion, drainage. And with that, we'll move on to the next case, which is percutaneous extraction of an embolized IVC filter strut embedded in the right ventricle. And Dr. Fischman will be presenting this case.
Actually,
it's actually me. Yeah. So this is actually a great case that comes to us from Pennsylvania, and what I found interesting and instructive here is that this is actually a 29-year-old who presents with sharpened chest pain. And then she has typical symptoms that would be pleuritic, like it's better with leaning forward than deep inspiration. She's slightly hypertensive, a little bit tachycardic. They check a pulsus paradoxus, and it's 16 millimeters of mercury. Then they go ahead and do an echo, which shows a pretty large circumferential pericardial effusion. So that's not quite what you expect with a 29-year-old presenting with this chest pain in absence of other risk factors. They do pericardiosynthesis, and then as they're doing this and doing an echo, they actually see a foreign object in the RV. You can go to the next slide, and you can actually see on these very nice on the sagittal CT, you actually see the IVC filter in there. So not what you would really expect of a 29-year-old who comes in with a with pleuritic chest pain. So they take a little bit more history, and they find out that the patient actually had an IVC filter placed. So this all comes together. So then, what do you really do with this? And I think what I liked about this is you can stay on this next slide as the one with the removal. Just go one forward. They essentially try to pull it out, and it actually doesn't quite work. So then they took an Agilis sheath, which is actually pretty big. It's more like a EP situation, and then they do, and this is actually really good educational here. They actually took a glide wire and then catch the glide wire with a gooseneck, and then to pull the whole thing out. So that's actually a good way of grabbing it, because it was actually a pretty large device. Go to the next one.
Wow.
A little bit of a slow. So on the next slide, you will actually see how they actually grab the device with a gooseneck snare.
Okay.
So, interesting case. I want to ask the panel is, have they ever seen anything like this? A young patient who presents with a dislodged IVC filter.
I hadn't imagined this one, I must say. It's a very good case. That is interesting that not only did it float, first of all, I have to imagine how this could have happened. And I wonder if this was a defective device that had a free-floating strut from the get-go, because this strut is essentially below the hooks. So if the device was secured, I don't understand how the hook can go free and embolize, particularly in a patient that wasn't instrumented again. One can say perhaps it was instrumented, someone pushed again with a sheath or another catheter from below, and got broken. So maybe it was a defective device, and this just flew right away essentially before it gets organized. What I find fascinating is that not only did it float, but it actually was secured in a certain place, and by the beat-to-beat action of the heart, it migrated towards the pericardium and caused the effusion. That is a tremendous, interesting scenario. So it's not really free-floating; it's somewhat in the myocardium and went through and through. It's fascinating that we're able to take it out.
Yeah, those hooks are dangerous.
Yeah, I would agree. This is a amazing case. I think first, taking a step back, it's pretty clear, at least to me, reviewing the data, et cetera, that IVC filters are not like in the days of old where you just put them in everybody, and certainly a woman this young. Typically speaking, protocols need to be in place where you try to put in a temporarily removable filter. The name is saved and on the calendar for the patient to come back to get it retrieved, because it's pretty clear these things thrombose not only locally, but they can migrate, they can embolize, and they're just not good situations when that happens. You have to be sure that this embolized fragment is not attached to anything before you pull it, because if you start pulling and there's resistance, you can move, and it's still attached, dislodge the entire filter and cause more issues. But in a very rare situation like this, it's a pretty inventive way of getting it out and avoiding surgery, which for most patients with migrating or embolized filters, unfortunately, that's what they end up having to have.
Yeah, and I think they were pretty lucky because this didn't get through its tricuspid valve and get caught in the chordate. Because I think at then, as you said, Ajay, that is not a percutaneous intervention anymore.
We've had a couple of cases submitted on these filters, and withdrawing them before they degrade or cause complications is a good message. We had one interesting case where during the withdrawal, the elective withdrawal of the filter, the hook came outside of the sheath. When they pulled everything back, it actually tore a hole in the right atrium. So you have to watch the hooks very carefully when you're withdrawing the filter, and they can cause problems going in, staying in place, or being withdrawn. So it's not a benign device.
Yeah. and the retrieval is not benign. That's another scenario. So we gotta be careful. That's the main message.
Yeah, I think the final take home I would say is that retrieval always sounds like a good idea, and there's several retrieval cases in this segment, but you have to be really cognizant of what other structures there are near where you're going to be retrieving and where you're cinching and pulling, because sometimes the retrieval itself can be more complicated and have more problems than actually leaving things in. In this case, you clearly can't leave it in given the clinical presentation, but it's an important point to think about.
So this object does not have a free end, right? So how are you going to use our regular snares? This was a really interesting case, but in general, how would you approach this case? So one end of the foreign body is in the septum and the other end is in the RV free wall. So we don't have a free end to put your snare around.
Well, hopefully it's sticking out a little bit.
Looking at this case, you wonder whether you would want to do this in the hybrid OR, and maybe a try percutaneous removal, but be ready to go on bypass, at least on fem-fem bypass or something, because if these hooks perforate, as Eric said, you can cause a lot of damage here.
I mean, another scenario here is to, since the indication was a pericardial effusion, this can be treated during a pericardial window, and then they can just pull it out. From the RV that way. That might also not be that bad. It's certainly a closed heart repair. That's another option.
All right. Can we move to the next one? And this is a percutaneous removal of pulmonary artery catheter that was sutured to the heart during valve surgery. And this will be presented by Dr. Fischman.
So, Mladen, another case from Pennsylvania. Sorry. And I hope we never see this. And I think it'll raise a few questions at the end. But again, I don't think any of us hopefully will ever see this in our lifetime. But basically, this is a young individual who underwent a mitral valve surgical repair, had a ring placed. And I should say, prior to this procedure, had an 8 French Swan catheter placed, and had the successful surgery. And she's 74, I think young, but 74. Had this right thoracotomy, valve repair, and the Swan was placed the day before. Everything was closed, and the following day they attempted to remove the Swan catheter, and they were unsuccessful in removing it. And as I said, I don't think any of us hopefully will see this. And if we can go to the next slide. And to try and keep this short, if we can go to the second slide.
Yeah, we are. It's great.
I guess I don't see it on my screen. It's like, oh, there we go. All right. And so what was determined was that this Swan was actually sutured in place during the closure procedure. So, and furthermore, not only was it sutured in place, but it was sutured through the Swan. And they recognized that when they tried to put some stabilizing wires, that this was a triple lumen port, that they couldn't advance them through it. And so you had this catheter not just sutured, but sutured through the catheter. And what do? Said they try to yank it. So I don't think we'll ever see this. And basically, using some therapies that the electrophysiologists use, when they try to remove lead placements and what have you, stabilizing these wires, they grab this from above and below, and they actually lacerated the portion above that was sutured. They used forceps and a snare, and they lacerated above, pulled it out. And I think basically when they say lacerated, used a lot of tension after holding it on both ends and pulled the top portion out. And then they did the same from below, basically below where it was actually sutured. Used forceps and gooseneck snared, and basically pulled out from below, removing everything but a small segment of the catheter that was again actually sutured in place. A tough case, and you can see in the next slide. We'll show the catheter in 2 parts. Basically, that. The top part and the bottom part, and very small remnant, they said, will just be, endothelialized with the course of time. Again, I don't think anybody in the panel will ever say they've seen this, nor should we ever see it. And I raised the question, and this is not uncommon, here's a patient who's undergoing this valve surgery. What's the necessity of doing the swan before they even do the surgery? How is it going to help someone you're going to put on cardiopulmonary support? We see this in transplants where we're asked to put in these swans before the transplant. They pull it back a little bit. Why not just place it afterwards? And I'm not sure if others see that same thing. And I think it also, as this case, the following case would say, what we really need to know about some of these retrieval devices, like in this case, the gooseneck snares, as we'll see in the next case. What have others' thoughts?
My sense of the utility of case reports is sometimes they're useful to show new techniques and how to get out of situations. And other times the primary learning objective is, this can happen and you should prevent it from happening so you never have to do what we tried to do. Because this is amazing that they were able to get a good result. I can think of a lot of ways that could have gone wrong. So to the point that you made about the swan, we tend to typically do these swans in these heart patients because, the anesthesiologists use them to manage the fluids and that sort of thing. But do there need to be mitigation strategies by the surgeons? When do you pull it back or otherwise during the course of the case is a good question to ask.
I mean, it seems very simple to just time and ask that the swan is pulled back and then re-advance. That there's no penalty for doing that.
We don't have any surgeons on the panel, but it just highlights the importance of the precision in placing the sutures when they put in a ring or a valve. I've seen a couple of cases where the circumflex artery was occluded by a suture with a mitral valve. I've seen where the right coronary artery was occluded by a suture from the tricuspid valve. So there are a lot of structures going there where they're sewing. They have to be very careful and precise when placing their sutures.
Yeah. I mean, if the suture was wrapped around the device, it'd be one thing, but they actually, how they can do this, put a suture through the device.
Yeah, you got to pull it back in surgery, right? That's what the anesthesiologist does. When the valve goes in, you somehow, it's as you said, David, you got to come back so that it doesn't happen. That's it's absolutely a unique, fascinating report.
I said, hopefully we'll never see this in our lifetime.
All right. Any closing comments, Dr. Fischman?
No, I think it's as Ajay said, it's fascinating to see this type of case. I'm not sure we're going to learn how to remove this device in the future. Other than that, it's happening. I don't think we'll see it again. Tough case. I wouldn't have been wanting to be involved with that, but I do think it highlights that the surgical team needs to make sure that thing is freely moving before they take the patient off the table.
All right, so moving on to the next one, we have a case of successful retrieval of a fractured and detached crown from a coronary orbital atherectomy system, which will be presented by Dr. Fischman as well.
So I think this case highlights, the importance, not so much, this is something I think, we do enough cases somewhere along the line, we're going to be asked to remove or try to retrieve some kind of device. And this is someone who underwent orbital atherectomy. And the crown became detached. And you can go to the next slide. It's an 84-year-old man, progressive chest pain and dyspnea, severely calcified ramus branch. They put a 7 French guide in and into the left main, and they went ahead and then they did orbital atherectomy of the ramus branch. And what they found in trying to remove the orbital atherectomy catheter, it became detached. The thought that this got caught on that it was some uneven plaque rotation, and it got caught on the calcified plaque. The actual thing became detached, and they were actually able to successfully go in with a guide extension catheter up to the device, put a snare into this, and capture this snare and remove the guide catheter, the guide liner catheter, and the snare catheter with the crown. And then went on to complete this procedure with the final stenting, got a good result. But for the harrowing moment of this thing becoming detached, I can imagine that there was a lot of sweat. But I think it brings, a lot of points up, and I'm curious to see what others think about. I think a lot of it is lesion preparation. One is a comfort level with these devices, whether it be rotational atherectomy or the orbital atherectomy catheter, and a good sense of the preparation, who we should be doing these procedures on, and being, prepared to use retrieval devices. We've seen stents get retrieved. We've seen orbital atherectomies. I've seen rotablator catheters get retrieved. I think it's important that as interventionists, we have a good feel for retrieval devices like snares, and how do we educate individuals, or do we just wait to when it really happens?
So I think, my comments would is definitely be prepared for some device to get stuck and or fractured, and know the algorithms for how to deal with it. It's, for rota at least, because the wire is stainless steel, one of the solutions that is not intuitive is you can pull back on the wire, and the weld is strong enough that by pulling back on the wire and putting the weld at the point of the distal part of the burr, it actually comes out. The CSI device, especially the newer wire, doesn't actually have a stainless steel wire like that, so you have to do that with a little bit of trepidation, and I probably wouldn't do that until there's better bench testing to understand that. But the point of trying to get either a guide extension, and you typically have to cut the back end of it to get a guide extension over to sort of focus your force directly. And then the other key thing is not to pull so hard, and this is true whether it's a IVUS catheter, whether it's a balloon catheter, anything. Don't pull so hard that the thing breaks, because it's a lot easier to manage if the shaft is intact than if the shaft is not intact. But this was a very good save, and a good report of how this can happen with the CSI device.
Yeah, I would say in the prior era, there was more time spent on proctoring and certification and paying attention to the learning curve on learning new devices. And I think with so many devices coming forward now, one teaching point here for the young and new operators is to be around an experienced operator and recognize there is a learning curve, and try to understand all of the complications and the corrections for a complication before you jump in on something by yourself and end up surprised by a complication you're not prepared to deal with.
So
it's really advanced PCI. It's not the routine low operator PCI that some of us have done in the past.
Oh, absolutely. Well, we didn't talk about the reason why this got detached. It was a device deficiency, perhaps because there is not an articulation that we put together, like on the rota, that get detached. The other factor is to point out that this case was able to be successfully performed, as we see in this slide, with serial balloon and cutting balloon dilations, and a 3.0 stent was placed. So at the end of the day, one can say and deduce that this was also a borderline indication for the atherectomy.
Yeah, no doubt, and that's the patient preparation and decision when to use these devices. I think the young trainees, the experience in the getting is much less than we had. It's clearly less than what I had when I did a lot of rotablade in my early days. And so when they go out in the real world, I think they're anxious to use these devices with little experience, depending on the program they're at. And that makes it problematic. And then on top of that is when you get stuck in a problem like this, what do you do?
And, it won't get less. You have this paper by Nirat Biohar and Ajay here from circ intervention. There's more calcified lesions. This will happen more and more. It's not that this is going to be less of a problem. I think I would see this happening more often with increasing complexity.
Good. Anybody want to give some closing comments on that, please?
Be prepared. That's the one thing. The only other small point to mention is, I think, for a lot of us radial operators, 6 French access is something that we use routinely. Bifurcations, atherectomy, et cetera. The one downside of 6 French when this occurs is that there is not typically enough room alongside the shaft of the device, whatever device it is, to get another balloon alongside if you have a wire. So in order to dislodge it, if you're going to do that, you may have to unfortunately go to a second access. The reason this is seared into my mind is because it actually happened to me yesterday, but we were able to get out of it.
Sorry to bring up memories.
All right, we'll move on to the next case, which is transcatheter closure of an iatrogenic RV perf with Amplatz duct occluder 2. This will be presented by Dr. Vidovich.
So this is actually a great case, and I like it because I think most of us have seen something similar, maybe not to this extent. So again, case comes to us from India. So 81-year-old, so somewhat elderly male, presents with syncope and shortness of breath. So then they go ahead, get an EKG, and see this is bradycardia and a complete heart block. So it sounds like not a big deal, right? So they go ahead, put a 6 French pacing catheter from the right IJ. Again, nothing literally unacceptable. Thresholds are okay, paced rhythm, and then they move on. So then 2020 was a year of COVID, and they find actually the patient is COVID positive. Gets hypertensive, he has high flow oxygen, and then they do a chest CT and see COVID-19 infiltrate. But lo and behold, there's also a pacing wire that perfed, protruded, migrated, whatever we want to call it, and causes a pericardial effusion. So that's no good. So they have a, say, iatrogenic or spontaneous, whatever you want to call it, perforation of the pacemaker wire with a pericardial effusion. So the good question is, what do you do now in an 81-year-old and you're dealing with COVID and you have pulmonary infiltrates? So what I really like what they essentially did is they decided let's close this percutaneously. So what they did is they took a Amplatz closure device, actually went through the perf, and we're able to successfully close this. So here you see this RV gram with the extravasation, right? Then they place the sheet of the RV gram where you can actually still see extravasation. Then you go to the next slide, and you'll see how they successfully sealed the ventricle with the Amplatz closure. So I'd say a very, very nice way of getting yourself out of a bind in a, I'm going to use the word unprecedented, but was an unprecedented year. And I don't know if we would have done this under non-COVID conditions, but again, good way to show how they got themselves out of the bind. So for the panel, would you have done this with a perf, or would you have sent him to surgery or done a drain?
Yes, they did it, and we presented because they were successful. And, that is, I think, the message. If you think you would be successful, you can do it, but you're essentially flying without a protective net underneath if you're not so successful.
So my guess is the RV leads perforate the right ventricle frequently, and they seal up somehow. I wonder if just a pericardial drain, an observation for several hours before they tried a unique intervention would have been a more reasonable approach.
True.
And another thing is that when we were discussing this case on our editorial board, there was a lot of question as, well, how do you look at this long term, right? Because RV moves, and will this erode? What is the arrhythmic potential? What is the short, mid, and long term fate of these devices in the RV free wall? And I think none of us really knows this. So as you said, George, you're flying without a parachute, safety net, one engine, not enough gas reserve, right? Yeah.
Good luck. You need some luck.
Any comments about why they may have used the ductal occluder versus the VSD occluder?
I think that's a minor point, whatever fits. Once you go down that pathway, whatever fits among the things you are available.
But I think to Eric's point, the majority of effusions, and it's not uncommon for EPs to have effusions after procedures. It happens. It's not common, but it does happen. Most can be managed by, pericardial drain. And in this COVID era, you can actually do pericardial. We've done pericardicenteses at the bedside with echo. It's interesting. The traditional cath lab way of doing pericardiocentesis is to do it with fluoroscopy and bring the patient down. But it's interesting. We had a fellow who trained at the Mayo, and the fellow explained to me that at the Mayo, the vast majority of pericardiocenteses electively are done by the echo team. And the way I see it is, in terms of risk aversiveness as well as sort of anti-cowboy behavior, the echo department fits that bill. So if they're doing a procedure that gives most cath lab attendings a little bit of pause every time you're sticking a big spinal type needle in a pericardium and the patient's complaining, et cetera, then maybe we ought to learn how to do it that way. And so that's what I did. I learned how to do it that way with echo. And I can tell you it's a much, much easier, safer procedure. And you can do it at the bedside, put a drain in and observe what happens. If the patient doesn't do well, then obviously then you look for more extreme measures.
I think that's a nice, great balanced review of this that I think perhaps most would have chosen to do a pericardiocentesis and then wait it out and drain it and see if it closes spontaneously and then do something like that.
Awesome. So moving on to the next case, this is the last one, coronary artery embolism caused by bioglue surgical adhesive following a type A acute aortic dissection repair. And this was presented by Dr. Eric Bates.
Okay, this is a 65-year-old woman who presented with an ascending aorta dissection complicated by severe aortic regurgitation and went off to a successful root replacement. They don't comment on what happened to the valve, but they replaced the root, and then they used this thing called bioglue surgical adhesive to help obliterate the lumen. I guess is routine. Again, we don't have a surgeon here, so I'm a little bit out of my expertise. But the patient did well, and then 12 days later suddenly developed chest pain, anterior ST segment elevation, and had a VF arrest that had to be shocked, and then went to the cath lab and was found to have a filling defect in the mid left anterior descending artery. We can see the next slide, please. So they tried to aspirate the defect and were unsuccessful. And then there you can see it, if you have an arrow or a finger.
Yep.
I tried aspiration with a couple different catheters and were unsuccessful. And finally, I put a stent down there and restored normal flow, and the ST segments came down, and they thought they were in good shape when suddenly the inferior lead ST segment elevation occurred, and they then injected the right coronary artery. And the mid-posterior descending, we can skip that, I think. And the mid-posterior descending artery had an abrupt occlusion, suggesting that there were two coronary emboli causing a double infarction. This time they were successful in aspirating the interluminal filling defect, and they pulled out this yellow gum-like substance, which on histologic examination was the bioglue. So this is the fifth case of a coronary embolization. The interesting question is, how does a foreign substance that's injected above the coronary go retrograde and down the coronary? And one possibility is aortic regurgitation could bring the material south. Another explanation is the vortexes of blood flow in the coronary sinuses might create some retrograde migration. And then the third possibility they suggested was when you put a prosthetic graft in there, you change the flow a little bit. But it appears that this foreign material migrated retrogradely and down 2 coronaries and caused both ST segment elevation in the LAD and in the right coronary artery. So with the LAD, they successfully restored flow with a stent. With the posterior descending artery, they successfully restored flow with aspiration, and the patient did well and went home. Although they didn't mention the infarct size, but it's a nice acute way of going through your coronary embolism solutions on how to restore flow. This could have been a vegetation. It wasn't. It could have been some calcium off a valve. It wasn't. It was glue. So if any of you have any comments on this, go ahead.
Well,
So Eric, I was just going to say real quickly, Eric, you found a good use for a thrombectomy catheter.
Yeah.
No, there are selected circumstances where it's useful, but in this case, making the diagnosis was unbelievable because it could have been any other embolization, but seeing the histopath helped it out. Sorry to interrupt.
Atrial fibrillation and just thrombus. That's right.
well, I mean, I'm amazed that first of all, this is a glue, or it's called a glue, but apparently it's not a glue, because if it was a glue, it wouldn't come out, and perhaps
It would stick.
The catheter wouldn't come out, or the wires wouldn't come out. It's not exactly a glue. It is probably some kind of a pasty material, and I suspect it probably goes down the coronaries at the time of the injection. And, you know, for whatever reason, it organizes later on or something around it. I just can't imagine that there was an acute embolization of these 2 big things this long after the surgery, but it might be the other possibility is that this substance, and again, that's a good point. We don't have a surgeon, but I don't have any experience with that, but maybe over time it blows up. So it's injected and it's of a certain volume, and maybe by exposure to the blood, it just grows. You know, again, it's called a glue, but it's clearly not exactly a glue.
Yeah, the other 4 cases occurred within a couple of days of surgery, which might be more reasonable to expect. This 12 days out is quite unusual, but they actually have a histologic picture you can't see too well there, where they actually have plaque and the histology of the glue. So you can see, and they proved it by histology that it was the glue, because it's not thrombus and it's not plaque, it's glue. So whatever you call this case, it embolized, and I think it was acute because with LAD they had acute ST elevation and VF, and then when they got back to stability, they had acute inferior wall elevation. So why it would go down 2 different holes is another curious question. But as was said earlier, I hope we don't see this again.
Yeah,
How do
it's
you
also
decide whether to stent or not to stent?
That's a great question, Poonam. I think that if you are able to extract it in toto, and the thrombectomy catheters do have uses, and for this type of case, it's very useful. But if you're able to get it out completely and you were to image and show that there's nothing there, then you don't necessarily have to stent. The challenge is frequently you won't fully get it out. And so if you don't fully get it out, you need to maintain flow and keep it open. And so sometimes patients will end up with stents.
Yeah.
I'm glad they send it for PATH as well, because, you know, frequently you do thrombectomy and you won't send it for PATH. You could have just blown this off and then this is just a thrombus. So I think that's a good piece here. But I don't know that we would send everything for PATH either. I don't think that's the message here.
Great. We're at the top of the hour. Can we get some closing comments from everyone before we close? Dr. Dangas?
This was a tremendously diverse and interesting session. We got a lot of saves reviewed, and we got an idea on several of them to never try some of the things, but also we were reminded about other things that can happen, and you know, how to be best equipped and algorithmic or organized on how to take care of them. Take our own pulse is always a good start.
I think those are great points, George. And for me, this is really very, very interesting. I commend you all for instituting this new journal. Case reports can be really, really educational, as I said, to know what can happen and then to provide mitigation strategies to avoid them, and then potentially the range of what could be done to get out of them. And sometimes the range of what can be done to get out of them is so daunting that it really reinforces that you really shouldn't try to have that complication in the first place. So thank you so much for allowing me to participate. This was great. And congrats to the organizers and to the journal.
Dr. Bates.
I would just remark on the wonderful job Julia Grapsa has done in launching this journal. As Ajay just said, case reports were not appreciated for a couple decades. You had to have randomized clinical trials, but I dare say if you click on this journal, since it doesn't get published in print, and read through several case reports, you'll have more learning opportunities than 10 or 15 minutes of reading that you will get in a traditional cardiology journal with review articles and observational and clinical trial research. The imaging is great. The format is great. You'll see all kinds of crazy cases, and you'll get really a good learning value for a few minutes reviewing this journal, which is now approaching 2 years in publication.
Great. Dr. Fischman.
Yeah, I echo what everyone has said. And, you know, case reports was originally designed to present novel diseases, novel techniques, you know, back in the day when they were more common. And I think that you know, we're often afraid to share complications. And I think the fact that we're sharing these complications is great. And I commend Julia that we are publishing complications, because it really gives us an opportunity to really discuss what can happen. And, you know, somewhere along the line, you may need to use the things we're learning. I mean, not all this is novel. Yes, it's, you know, shocking, some of these things, but I do think that the case reports and JACC is really giving an opportunity to share complications and how we can learn from each other. And even this webinar, I think, is a great opportunity that we can learn from each other, you know, little tidbits of how do we manage our patients.
Dr. Vidovich.
Yeah, again, just to join in thanking Dr. Grapsa and actually leading this journal really well for the last 2 years. And what I would say about case reports is I think most of us have started our publishing career with a case report. I think that's a great way to get your feet wet. And my first publication is a case report, you know, and you learn from them. They're dynamic, and I think the best about them is they're so well suited for social media. I think our social media presence is completely exploded because they're quick, they're bite-sized, and people love them. So again, really been a good ride so far.
Yeah, thank you, everyone. And I echo everyone's comments. As an early career cardiologist, I think this has been very, very helpful, and just great comments from so many experienced interventional cardiologists. I'm sure the audience will love this. Thank you all so much.